We're going to get started. And we've got 10 interesting cases to go over this morning. And these are just kind of group of interesting kind of unknown cases. So these are potpourri, not really related to any specific topic. And what I would want to, a little shout out for the Zola Cooper Clinical Pathology Conference. It's coming up on November the 14th. A lot of you guys are going to watch this later online, which is fine. But that course is going to be in the morning of the 14th. And we have about 50 very interesting cases with clinical pathologic materials, just like you're going to see here with case discussions by experts in the field, myself, Dr. Tom Davis, Mark Kappel, and Lori Prock from Colorado, and then Travis Vandergriff and Sandra Oswald are the clinical moderators. And so if you want to sign up for that, www.zolacooper.org, and go to that website. You think we've got about 6 people that have already signed up. It's I don't think there's a cost at all for residents to join. So if you want to come on and look about some interesting cases, learn some stuff that'll help you with your boards and just nothing else, just really good clinical pathologic correlation, strongly urge you to look into that. So let's start off. We got a punch biopsy. You can see it's kind of been bisected here. And at low magnification, ask yourself whether it's inflammatory or neoplastic. We don't see any neoplastic cells in here at all. We do see a lot of cells that are kind of clear here. So once again, when we think of things that are clear in the skin, low power, and if you're thinking of an inflammatory process, think about the possibility of a granulomatous infiltrate, because histiocytes tend to be pale. They tend to be lighter than lymphocytes or neutrophils or eosinophils or mast cells or any other cells. So when they look low power, like they're kind of clear like this, you want to think of granulomatous inflammation possibly. And we've talked ad nauseum about the different patterns of granulomatous inflammation. But there is another differential diagnosis for things that are clear in the skin that I want you to know about also, besides just thinking of histiocytes with granulomatous inflammation. So you can get clear as a consequence of lipid. So histiocytes or cells that have a lot of lipid in their cytoplasm, that can give you a clear color under the microscope. If there's a lot of glycogen, that can also give you a clear color under the microscope. We see, and glycogen can be within often in epithelial cells. So we see like glycogen in the cells of the tricholimal root sheath of hair follicle, have a glycogen in those, and the glycogen that's present inside the cells of an eccrine sweat gland. So glycogen is in there. It also is present in certain neoplastic cells. So we get glycogenated cells there. You can also get clear discoloration from other types of material inside cells, like, for example, a renal cell carcinoma. That's clear, probably because of lysosomes and things like that in the cytoplasm of the neoplastic renal cells. Maybe some glycogen in there too, but it's not lipid. And then you can get clear discoloration because of the balloon cell of a melanocyte, for example. So a lot of different things give you clear cells in the skin, and you really need to have kind of a differential diagnosis of that. But the most common are probably histiocytes that contain either something in their cytoplasm or that contain lipid in their cytoplasm. Here's a nice example of sebaceous glands. Notice that's got clear cytoplasm, so we'll use that to kind of compare with the cells here. And now we've got these cells that have these little tiny bubbles in their cytoplasm, lots of little bubbles in the cytoplasm. I think I mentioned this before in one of the sessions a few weeks ago, is that if you see tiny bubbles inside histiocytes, you should think about the possibility of silicone that is present in the skin for one reason or another. And there's two main ways you get silicone in the skin, and this is distinct from silica. Talked about that a couple of weeks ago too. Silica is a crystal, glass. Silicone is an element, Si, and elemental silicone is injected for cosmetic purposes. And so people get that either in a way that is medically indicated, like a doctor that's using industrial grade, high quality silicone that's got no impurities in there, or people that get it done in an illicit fashion want to maybe increase the size of their buttocks, for example, or they get it in a lot of sex workers used to inject breast and buttocks with silicone in Mexico and things like that. Fortunately, a lot of those people, unfortunately, a lot of them would get serious complications from that. The material would migrate and actually can get into blood vessels, cause pulmonary emboli, thromboses, all sorts of bad things. So really don't want to get that. And that kind of silicone is not industrial grade. So this was something that was injected. And you can see it's been injected relatively superficially in the skin, and it was probably done to try to get rid of wrinkles. Usually that silicone is injected a little deeper. So this might have been a little bit too superficial. Might be why they actually got a reaction to it. And if you see clinically, you see the next slide, they get these bumpy, lumpy areas that you really don't want to get with the silicone injection. Normally it should be just kind of get rid of the wrinkles and not really give you any inflammation or any papules like you see here. This is silicone granuloma. So if you get this, they're hard to get rid of. You have to excise them. Some people will inject them with some steroid to try to decrease the inflammation that's there, massage, things like that. That helps. But unfortunately, once this stuff is in there, it's kind of in there forever, and it's hard to really go away. So you have to kind of decrease the inflammation. Okay, let's take a look at this. And once again, we've got a deep punch biopsy that's been bisected here. And we've got, let's look at this one over here. So certainly not a neoplasm, inflammatory. And low magnification, you see that there's something going on up here in the epidermis. So we've got an ulceration here. And we've got all these changes down the subcutaneous fat. So we've got a paniculitis. It's probably a dermatitis plus a paniculitis. And we've talked a little bit about paniculitis. So this is going to be a lobular, mostly paniculitis. Notice that all the lobules here are involved. Septa involved too, but it's mostly lobular. And go to higher magnification, see that there's this calcification, extensive calcification involving these blood vessels. It's a relatively, it's not a large blood vessel, but it's certainly not a tiny capillary sitting down here in the lower part of the dermis subcutaneous fat. So it's probably either a venule or maybe an arteriole that's calcified. You got some other calcifications over here, capillary that's calcified here most likely. And then you've got some calcification that's probably present just in the soft tissue up here, just in the dermis. So we've got the spicules of calcium. We've got calcification of blood vessels. We've got some calcification of these elastic fibers. And sometimes when you get calcification of the elastic fibers, they can take on a pseudoxanthoma elasticum-like morphology. We talked about PXE, I think last time or maybe a couple of weeks ago. And you go to the top of the specimen, you can see this collagen is degenerated here. And now we've got ischemic necrosis that has basically killed the epidermis and resulted in an epidermal an ulcer here. This is totally necrotic epidermis here. So the cytoplasm is pink, homogeneous, nuclei are pycnotic, there's karyorrhexis. So basically you've got a completely necrotic, mummified epidermis, degenerated dermis, thrombosed blood vessels, calcification of some blood vessels, and then this paniculitis, which is due to this degeneration of subcutaneous fat. So this is a classic example of calciphylaxis. We see this in patients that have renal failure. Used to, when we first started seeing these cases 25, 30 years ago, and this is, what happened a lot of times when patients really had bad renal failure and they had hyperparathyroidism and had a calcium phosphorus product abnormality. Most of these patients would die. We recognize this disease better today. Patients are treated more aggressively now, and not all of them die. So it used to be a death sentence, but it's not necessarily today. And some people actually can have kind of a low grade, sort of a slower progression of this condition than when we used to see this. So really not a good disease. Basically, it can be fatal. You want to recognize it as soon as possible. Sodium thiosulfate can be used for this, but you need to really get their calcium and phosphorus product back to normal as soon as possible, get their parathyroid hormones leveled down as soon as possible. And a lot of these patients will get emergency parathyroidectomy if they have this disease. And here you see the classic sort of reticulated changes in the skin. This is all manifestation when you get this reticulated purplish discoloration, this sort of gunmetal gray appearance. That's a sign of underlying ischemia. And basically you're looking at an infarct, and all that skin at some point is going to slough when you get that. So you've got some eschars that have already formed over here. You've got some reticulated change over here, and a lot of those may end up looking like this as time goes on. So this is calciphylaxis. Again, not a good situation. Make sure that you recognize the clinical features of this, and if you do a biopsy, make sure you get a good deep biopsy all the way down to subcutaneous fat. Sometimes when you get this disease early, you'll just see these little tiny spicules of calcification, sometimes just a few, not the calcified blood vessels, just little tiny areas of calcification just in the subcutaneous fat. So you really need to make sure you take a good deep biopsy down into the subcutis. So it basically is a manifestation of thrombotic vasculopathy. It's associated with protein C and protein S deficiency when you get this. The calcification may actually cause the vascular compromise itself, but it's usually associated with some thrombotic changes also in addition to the calcification. Okay, shifting gears a little bit here. We've got another punch biopsy, and we've got a process that's situated in the dermis here. And low magnification, you can see that it's got these dark staining cells here. So we're going to think that a lot of these are likely going to be lymphocytes. And notice that it's kind of got this teardrop shape morphology here. And that's helpful in this condition. There's another one on this side. So a little, almost looks like these little teardrops, if you will, kind of dripping down from the upper part of the dermis. You can get involvement in the upper part of the dermis, but when you see a lesion that's comprised mostly of lymphocytes at low magnification, that's involving the bottom half of the specimen versus the top half of the specimen. So bottom heavy versus top heavy. We tend to think of that as being more characteristic of a cutaneous lymphoma as opposed to a pseudolymphoma or benign lymphoid process. Now that's not 100%, because you can actually see this specific type of lymphoma involving the upper part of the skin also. So it doesn't have to be down here, but when you see it here, you certainly should favor the possibility of it being a lymphoid process that's more likely going to be malignant. And so higher magnification, you can see that it's got these clear areas, and those are going to be comprised of follicle center cells. And notice over here, normally if you have a normal lymphoid follicle, you've got the normal lymphocytes at the periphery, and then you've got the central lymphoid follicle with the benign lymphocytes at the periphery of that. If you get these lymphomas, sometimes you get this what's called inside out follicles, where the follicular center cells are not confined to the center of the lymphoid follicle. They kind of spread outside of that, like here. So here we've got the centrocytes that are kind of at the periphery, and then the small lymphocytes are in the center. So this is the opposite of what we should see. So once again here, you got this follicle, or what's sort of a poorly formed follicle, that's got all these sprinkling of these lymphoid cells within it. So normally you get lymphocytes at the periphery, the nice follicle at the center. Here you've got the lymphocytes that have invaded the follicle, and here you've actually got the centrocytes of the follicle that kind of invaded outside their follicle area. So when you see that, that's a pretty good example histologically of what we call a follicle center cell lymphoma. It's a B-cell lymphoma. It is an extremely low-grade type of cutaneous lymphoma, especially when it arises in the skin itself. And these lesions have a 99% 5-year, 99% 10-year survival in many cases. Occasionally, we'll see a patient that'll pop up with lesions elsewhere. They'll develop a lymph node or whatever, and they can have a relatively low-grade manifestation of their process. But it's really, years ago, we used to call most of these pseudolymphomas. Now, these generally do not have eosinophils in them. If they do, they'll just have a few. They won't have as many as we see in a pseudolymphoma that may have been precipitated, say, by an insect bite reaction or rupture of a cyst or follicle. So that helps you with the diagnosis. And then you don't get that nice, well-formed germinal center like we see on the classic pseudolymphoma. And if you do see it deep to the skin like this, that would favor this being a a follicle center cell lymphoma when it's got this pattern. The differential diagnosis of this will include so-called marginal zone lymphoma, where you get more plasma cells, plasmacytoid cells. This one does not tend to give you those plasmacytoid cells to the same degree. So if you see the plasmacytoid cells or plasma cells, that favors marginal zone lymphoma, that a very high percentage of cases will demonstrate light chain restriction, either with kappa or lambda. Not always. Actually, sometimes you'll biopsy one lesion and it's got polyclonal, and then you'll biopsy another one and it's light chain restricted there. So we tend to think of these things as reading the textbooks, but they don't. One marker that I like for this is a BCL6 stain, which highlights those central cells. BCL2 will be positive in this also, but BCL2 will highlight T cells. And even though this is a B cell lymphoma, it's going to have a lot of T cells in it also. We used to teach, what I was taught is that these things are B cell or T cell, and if they don't have all T cells and they don't have all B cells, they can't be a lymphoma. Well, that's not true. At least today, you can have a lot of T cells. We used to call these things in the old days T cell rich B cell lymphomas, but now we know that all the B cell lymphomas have T cells in them also. So they're all T cell, at least partially rich, in addition to this. But if you see this BCL6 staining in the center of this lymphoid follicle like this, that strongly favors this follicle center cell lymphoma. If you get a BCL2 staining in this same pattern, that suggests that it might be coming from an internal follicle center cell lymphoma of the skin secondarily, but beware of T cells that stain positively with BCL2. And these lesions can look like this. They can look like just one little lesion, like not this big plaque-like lesion. Sometimes they're just one or two of these lesions, so they can be relatively small. And again, they have a very good prognosis. In fact, there's some other lymphomas that have a worse prognosis of this that have been downgraded and called lymphoproliferative disorders. They're not even calling them lymphomas anymore because they have such a good prognosis. If you ask me, they probably ought to consider classifying this in the same way, because these patients do extremely well. They don't really have a lot of bad prognostic outcomes. And you can treat these with sometimes intralesional Kenalog, with surgical excision, local radiation therapy, and we're talking 1,000 Roentgens, or 10 centigrade or whatever. I don't know what they classify the centigrade classification, but I was taught, we were raised in Roentgens and years ago, and 1,000 R would basically wipe this lesion out. Very short radiation therapy and just melts away. So that's one of the ways you can treat these lesions. So just remember these. There's some other stains you can do. I don't think you really need to do all these stains really, but I find if you basically just do CD3, 20, demonstrate that there's a large B cell component, highlight it with BCL6. If you want to add CD10, you can, but I don't think you need it. Really favors the diagnosis in this case. Okay, let's move on to this case number 4. And we've got a shaved biopsy. And the pattern here is also going to be inflammatory. Really wish we would have had a punch biopsy here to see how deep this infiltrate goes. But sometimes if the clinician is thinking this might be a neoplastic process, they may do a shaved biopsy on it because this can give you a lot of pseudoepitheliomatous hyperplasia that can simulate a cancer. And that's an important teaching point that we'll talk about here in a minute. So we've got a shaved biopsy. It's got a lot of inflammation here. It's got all this epidermal hyperplasia, but that's all going to be pseudoepitheliomatous hyperplasia here. And you can see that there's some lymphocytes here, but not all the cells are really jet black like we see with lymphocytes, like in the last case of the lymphoma. So maybe there's going to be some neutrophils here, and then we may also see some histiocytes in this infiltrate. And indeed we do. We've got these histiocytes in the background. There's a multinucleated histiocyte there. There's some other histiocytes here. There's a lot of neutrophils here. We're going to look up in the epidermis here, and we've got an area where there's an abscess within the epidermis. So that's another finding that you characteristically see in these infectious diseases. Another area over here where there's a lot of neutrophils. So this is an example of a suppurative granulomatous dermatitis. And when you see this pattern with the pseudoepitheliomatous hyperplasia, I want you to be thinking in terms of a deep fungal infection or possibly a manifestation of a cutaneous atypical mycobacterial infection. Tuberculosis varicose cutis or something like that, maybe could give you a pattern like this. but basically we're looking at something that could be an infection. Whenever you see something like this, then you need to go on a bug hunt and start looking for the presence of organisms. And in this lesion here, I don't know if we're going to be able to see any organisms readily in this field here, but this was an example in this case. If I can find an organism, and the best place to look is either in the abscesses, often in the epidermis, because these organisms get transepidermally eliminated. So if you look up in an area like this, you might be lucky enough to find some. Don't see any so far. And then you want to look if you can see multinucleated histiocytes. That's also helpful. But I can tell you that what we actually did find here, I don't know which field it's in, maybe you look at one of these others, you might be able to see one. This was an example in this case of Coccidioidomycosis. And sometimes you'll see a lot of organisms. Here's an area, there's some degenerated caseation necrosis. Here we go, we got one right here. Look inside the histiocyte. That's a good place to look, is inside the multinucleated histiocyte. So look there, and look in the abscesses, and look in the epidermis where these things get transepidermally eliminated. And we've got a spherule. So here's an organism here with 3 or 4 little micro spores inside there. It's as high as we can go with this scanned image, but this is cocci. And you should all know where this organism likes to live. It lives in the lower Sonoran life zone area, Mexico, Arizona, places like that. And find another one here for you maybe, but this is an example of cocci. It's got a fuzzy view here. So but anyway, you got to see one. So I guess that's your quota for this. But just remember that basically it can give you these kind of crusted verrucous lesions like this. Often occurs in people that have lived in those endemic areas, and then later in life they may get something that causes immunocompromise. Usually this disease presents with flu-like illness. They get pneumonia, they think they got the flu or something. And then the next thing you know, they've got years, and they get over that. And then years later, they get diabetes, or maybe they get cancer, they get immunocompromised for one reason or HIV infection. And then they pop up with a widespread eruption, and you biopsy it, and lo and behold, you'll see evidence of cocci in there. And we actually see a few cases a year in our laboratory. We're not actually in the lower Sonoran life zone area in Dallas, but we see patients that come from that area. We see patients from Mexico, and so they can get cocci, and they bring it to our area. So just remember, suppurative granulomatous dermatitis with pseudocarcinomatous hyperplasia. Think infectious. Start looking for organisms, and then look for the spherules of the endospores for cocci. Look for blasto, rhinosporidiosis, which we really don't see in the United States very frequently. Much larger organisms. That's not even really a fungus. Actually, it's more of an organism that lives kind of in an area of the genetic tree, kind of close to a parasite and a fungus. So it's a little different organism, interestingly enough. And it's much larger than you see with cocci. The other organism that can give you this pattern is sporo. And sporo can give you lots of inflammation with very few organisms. So it's hard to see sporo a lot of times. You'll have to culture that to make a diagnosis. And sometimes if you see the organism, it's great, but 40 to 50% of the time we flat just don't see it. Okay. Let's move on to the next case. So if you ever see something like this, if the board examination gives you something like this, where you've got a vertical and a horizontal section like this, you should immediately be thinking you're dealing with an alopecia. So they're not going to give you something like this in a neoplastic condition. They're not going to give you something like this in like an infectious disease. They're going to show you something like this when they really want you to look at both of these pieces, and they want you to be able to diagnose an alopecia. So we've talked about alopecia before, so we don't have to necessarily go through the algorithm, but you can see here we should normally, on a section like this, we should see about 7 or 8 follicles that are rooted down here in the subcutaneous fat that are an anagen. If you don't see that, the person doesn't have enough hair. Okay, so right away you know that you're dealing with an alopecia. So then you're going to ask yourself, well, is it an inflammatory? Is it non-inflammatory alopecia? Is there scar or not? If there's scar, where is the scar located? If there's inflammation, where's that inflammation located? You know, is it present at the base of the follicles? Is it present more superficially, like near the infundibular follicles? Is it diffuse? Same thing with the scar. Is it around the infundibula, like you see with lichen planopilaris? Is it really kind of diffuse, like you see with ruptured follicles with something like folliculitis decalvans? So you're going to ask yourself all those various things. If there's any fibrotic tracts, the sites of extinct follicles, it's not really exactly scar tissue. That's going to help you. Are there fibrous stelae sitting on the subcutaneous fat? That's going to help you. So, and then are the follicles all in the same stage of evolution? Like in alopecia areata, you may not get much inflammation in alopecia areata sometimes if everything's been shifted. It's in the same stage at the same time. That favors AA. So here we don't have a lot of inflammation, don't have any scar, so we're not really dealing with scarring alopecia. We've got what looks like one follicle that's in catagen, another follicle that shifted into catagen. This follicle over here may be kind of late stage catagen, early telogen over here. So there seems to be, in this follicle here, a synchronization. This isn't as good as some examples we see. Sometimes you see 7 follicles, all of them are in catagen at the same time with some inflammation at the bottom of them. If you see that, that's alopecia areata until proven otherwise. You should think alopecia areata if you see that. So this is not the world's best example. Here's maybe a little bit of residual peribulbar inflammation, a little bit over here too, but this isn't our best example of it. So if you see in that section, go over and take a look at the horizontal section. And here it's a lot better. We've got more follicles to look at. We've got about 20, and we've got 3 or 4 follicles here where there's nice peribulbar inflammation. So this is a little challenging because it's not as classic as the beautiful example that you'll get on the board examination, but you can still make the diagnosis on the basis of synchronization, multiple follicles and catagen at the same time. And then the vertical section you got over here, you can actually see the examples of these follicles with that peribulbar inflammation. Not around every one of them. So again, these don't read the textbooks, but you've got enough of it here and you don't have anything else that it could be. It couldn't be lichen planopilaris. Doesn't have involvement of the follicles at the right location. There's no scar. You've got the synchronization of the follicles, multiple follicles and catagen. You don't get that in lichen planopilaris. And you've got these follicles here that are in early stages of telogen with a little residual inflammation. So this, alopecia areata can be synchronized, but again, you get one episode, kind of goes away, get another episode. So you may see one that's in an early stage where there's still some inflammation, one that's maybe in kind of a later burned out stage where you've got some fibrous stelae. So maybe they've had 3 or 4 episodes going on here at the same time. So you'll see different stages of alopecia areata going on at the same time with different manifestations of alopecia areata at the same time. That helps you with the diagnosis as well. So this is AA, and you all know what that looks like clinically. There's lots of different manifestations. Alopecia universalis, where you'll get no inflammation, no residual hair follicles, just little fibrous stelae. If you were to biopsy something like this, you'd probably see something more like what we're seeing today. If you biopsied something like this, again, you might see more than one kind of pattern in there. You might see an area that's kind of late stage and burned out. You might get an area that's kind of relatively acute, same biopsy. So you might see, more than one pattern. So again, it's a pretty good example of alopecia areata. Just remember that it's a non-scarring process, but it can be permanent. So you go back to that kid that had the alopecia universalis. We'd like to turn those follicles back on. We may use, Janus kinase inhibitors and things like that, squaric acid dibutyl ester to try to stimulate those follicles. But in many cases, once they're turned off, it's really hard to get them turned back on. So that's something to just, it can be permanent, but not really scarring. Of course, if you get a scarring alopecia, it burns out the follicles and gets rid of the stem cells. That can be permanent scarring, never going to come back unless you do a hair transplant. So dermoscopy, again, look for the exclamation point hairs. Look for the pulpicus constrictors, where the follicles are kind of thinning there in the hair shaft, and then the little yellow dots. So they may ask you some questions about dermoscopy of, of alopecia. That's a fairly new thing in our field, and the trichologists are using that more and more for bedside diagnosis, so it's helpful. But just remember these various things we talked about before. Telogen effluvium, you're going to get follicles that don't have any inflammation there. Androgenetic alopecia, no inflammation there. Trichotillomania, you certainly don't get synchronization of the follicles. You'll get trichomalacia. Now, one sort of thing to remember, in alopecia areata, you can sometimes get trichomalacia in that situation too. And in my opinion, the way I really think that happens is as patients start losing their hair with the alopecia areata, they start saying, wow, my hair's falling out, and they get a secondary trichotillomania because they start helping it along. They say, hey, my hair's falling out. They want to test it all the time. So they actually get a secondary trichotillomania on top of their alopecia areata. So it's not just trichotillomania alone. So you don't want to, misclassify a patient that's got AA and just say they've got trichotil when they really don't. Okay, a shave biopsy here. So we're looking at something that is non-inflammatory this time, a neoplasm. Move it up here, not going up very well. And you want to look at this field here. So we've got a neoplastic process, benign or malignant. It's hard to tell. Got a shave, extends both sides and top to bottom. Maybe malignant because it's pretty broad. We don't know how broad it is, but it goes from side to side and top to bottom. So it's probably part of a bigger lesion. That might favor malignant. We're going to probably have to look at other ancillary features. Can we assess symmetry and circumscription? We know it's not, we don't know for sure because it goes from side to side and top to bottom. So we really can't tell any of the architectural features on this. All we know is we've got a shave biopsy into some kind of a neoplastic process here. So we're not sure if it's benign or malignant. What kind of differentiation is exhibiting? Well, low magnification, it looks like it's a spindle cell lesion. Spindle, we tend to think of non-epithelial. Can be epithelial, but we tend to think of non-epithelial when it's spindle in shape. So we're going to go to higher magnification. We're going to have to use ancillary criteria to help us make a diagnosis here. So when it's spindle like this, we're going to higher magnification. Are the cells pleomorphic? Well, yes, they are. They're varying size and shape here. There's one that's got some cytoplasm, a little vacuole in it. That's probably in mitosis right there. These cells are pretty pleomorphic. They're not strikingly bizarre and atypical, but they're pleomorphic. And there's a lot of cells per unit area. And there's also somewhat of a fibromucinous stroma here. So once we see something like that, we're probably going to end up having to rely on special stains here unless we can see anything else that can help us. So let's ask ourselves, is there anything going on in the epidermis that may be contiguous with the lesion? Up in here, we've got more of an epithelioid area. So we've got spindle in the bottom, more of an epithelioid morphology at the top. And here's a mitotic figure here. So we're dealing now with a malignancy. So this is not symmetrical. We've got an epithelioid area here. We've got spindle areas in another area. That's a sign of asymmetry. Boom. More likely to be malignant than not. We've got atypical cells, looking cytology. So again, we can't rely on our architectural features here as well. So we're having to use secondary features. So we've got atypia. We've got mitoses. Have we got any epidermal involvement? Well, we don't have anything that looks like squamous epithelial involvement or anything that looks like an actinic keratosis, for example, that's contiguous with this. So that would militate against a squamous cell carcinoma. Do we have any intraepidermal melanocytic proliferation? Well, I don't know. We might have a few cells over here. It's not a slam dunk, but there's certainly some single cells here. So we might wonder, could this maybe be melanoma? Whenever you see a spindle cell malignancy in the skin, the three number one things to think about in dermatology are melanoma, atypical fibroxanthoma / pleomorphic dermal sarcoma, which just means AFX that's bigger. And then we think about squamous cell. Those are the three things. There are others. You can get, leiomyosarcoma, you can get angiosarcoma, you can get, some of the others, DFSP, the other sarcomas, but those are less common. And those are usually much larger dermal. They're bad situations. When you're dealing with the three most common ones we think about are the squamous cell, AFX, and melanoma. And the reason we think about those is because those are relatively small papular lesions that are biopsied by a dermatologist. Usually an angiosarcoma, if it's spindle, that's going to look like a large giant neoplasm that no one's going to confuse with possibly a skin cancer. So they're going to think about that as more of a soft tissue vascular neoplasm, or a DFSP, a multinodular type lesion. So we think about those three most common ones most commonly. So we probably would end up doing immunoperoxidase stains in a case like this. In this case, this actually happened to be strongly positive RS100 protein in SOX10. So this was an example of malignant melanoma. It's got an epithelioid component, and it's also got the spindle cell component down here. So in this area, at least in the bottom part of this, we would think of this as being a desmoplastic malignant melanoma. And desmoplastic malignant melanoma can be very difficult to diagnose. Clinically, they can look like this. They can look amelanotic. They can have an oligo-malignant component overlying it. You can sometimes see intradermal melanocytic proliferation overlying it, but you don't have to at all. You can see desmoplastic melanomas that have no epidermal involvement whatsoever, and it's still a melanoma. So you should not say that there's no epidermal involvement, therefore it can't be a malignant melanoma. You should always, if you get one of these poorly differentiated spindle cell lesions, work them up. Make sure you're not dealing with melanoma, which is by far the worst of the three. So again, you want to make sure that you're not missing a melanoma. The good news about desmoplastic melanomas is it sometimes can have a better prognosis, thickness for thickness, than other types of melanomas, but that's no guarantee. A lot of people talk about the so-called pure versus the mixed type of desmoplastic melanoma. I'm not a big fan of that because I think even the so-called pure type can end up having a bad prognosis. Also, I saw a pure type a few years ago that just had a beautiful dermal, purely desmoplastic melanoma that looked like a neurofibroma, wasn't very atypical at all, turned into a sarcoma and killed a young individual. So beware of that. It's out there, it's in the literature, but you can kind of sort of say, well, we hope it's going to have a good prognosis, but that doesn't mean anything. You still have a very bad prognosis with those lesions on occasion also. So I'm not a big fan of using that. For some reason, this clinical slide is not coming up to tell us about the clinical features, but I've explained it to you. They can look like scars, they can look like cysts, they can look like fibromatous lesions clinically. Under the microscope, there can be two patterns. There can be one that's more of a diffuse, delicate spindle cell type with a myxoid stroma that can look like a neurofibroma. That's the so-called pure type. There can be a type that looks more like a scar with a lot of thick collagen bundles in there. So in fact, a lot of these, unfortunately, have been previously diagnosed, biopsied and missed. Diagnosis was not made. And if you get a scar plus a desmoplastic melanoma, then it's really challenging to diagnose. So I like SOX10 because S100 protein can be positive in AFX in some cases. Basically, SOX10 is a more specific marker. And, get like HME45 and some of those we know are very commonly negative. 85% of them are negative in desmoplastic melanoma. So you can't use MART1 and HME45 antigen to diagnose desmoplastic melanoma. S100 protein usually positive, but I've seen some S100 protein positive negative desmoplastic melanomas over the years. So again, SOX10 is a better stain in our hands. Okay, let's take a look at this one. So we've got a deep, probably a punch actually. This is probably a punch or an incisional biopsy. Is it inflammatory neoplastic? We've got a diffuse process here, inflammatory condition. Notice that it's got a little Gren zone here. So this does not have the pseudoepitheliomatous hyperplasia that we saw before with the Cocci case, but it's got a dense diffuse infiltrate with pale staining cells. So some of these cells in the background too are lymphocytes, but others you can tell are not quite as dark. So I'm going to just tell you from looking at a couple of million slides over the years, some of these are going to be plasma cells. You're going to say, well, how did you know that? Well, again, I don't necessarily think you need to know that. When you go to higher magnification, you're going to see that some of them are, but it's because they're not quite as dark at low magnification as plasma cells, and they're a little bit different color and tinctorial characteristic than neutrophils. But the pale cells are histiocytes. We can all agree on that. So we're going to go to higher magnification. Once again, we see lots of histiocytes in a diffuse pattern. We should think about the possibility of an infectious disease. And as we get to this power, we can start seeing that there are these cells that contain these little holes in them again. And once again, clear with these little teensy tiny organisms that are clustering at the periphery of these histiocytes. These histiocytes have been parasitized by these organisms. And notice that they're clustering at the periphery. That's what we refer to as the marquee sign or the Ferris wheel sign. I like to call it Ferris wheel because in Texas, at least, there's a Ferris wheel down at the State Fair of Texas in Fair Park that's got these little cars at the periphery. We call it the Texas Star, and it looks like a little Ferris wheel. Each one of these little organisms of Leishmania looks like one of the little Ferris wheel cars, if you will. So this is cutaneous Leishmaniasis, and this form of Leishmania, usually where you get the marquee sign, is more commonly seen in patients that have got the New World type of Leishmania. And lo and behold, plasma cells. There's a lot of plasma cells in the infiltrate. So Leishmania, interestingly enough, as opposed to giving you a suppurative granulomatous dermatitis, tends to give you this eruption with all these histiocytes in it with plasma cells. I don't know why that is. Don't ask me. We need to ask our molecular geneticists that work with infectious diseases, but some diseases like syphilis love plasma cells. This condition also likes histiocytes and plasma cells, whereas cocci and some of the others like suppuration and neutrophils. So here we've got, down here, we've got lymphocytes and a lot of plasma cells that infiltrate here associated with the histiocytes. So you ever see that at low magnification, and you can say, you know, this has got a grin zone. It's got these cells that look like they're pale. You can dazzle your colleagues by saying, you know, this is, I bet you it's going to be Leishmania, and you go to higher magnification, boom, to make the diagnosis. So that's Leishmania, and that's probably the New World type as opposed to the Old World type. So maybe the lesion might look like this in the case that we've got right now, because it doesn't have a lot of ulceration or any verrucous change in the epidermis. You can get some epidermal hyperplasia. Like in a lesion like this, you know, you would think you'd probably get some epidermal hyperplasia, same thing over here, but this lesion probably wouldn't have so much. And sometimes you don't get the hyperplasia, it just ulcerates in the center, and it's still Leishmania. So remember, there's two types. There's the New World type, the Old World type. Leishmania tropica and mexicana is generally the type that's associated with New World disease. L. tropica is often seen in the Old World type. And then you get the sand flies differ. You get the phlebotomist fly in Old World. You get the Leutzomia fly in the New World. And we see this in the United States also now. We actually see cases in Texas. We get a few endogenous cases. So it doesn't always have to be brought up from Mexico or something like that. We see people that have never been out of the area that are getting it. So the organism lives in the United States now, and it's been transported up from Mexico, and it doesn't just have to be in the south part of the United States. It can be seen up in North Texas. We actually wrote that up a few years ago. Okay, let's take a look at this lesion here. Two pieces. Let's take a look at this piece over here first. And we've got a punch biopsy. Again, lesion located in the dermis, and low magnification that's got lots of blue cells in the dermis. And it's very, very dense, very diffuse, all the way from this part of the dermis here all the way to the bottom. Now, I don't know what kind of cells these are at this power, but they're blue. And we think of blue in the skin, we think of bad. So when something is blue or purple, immediately I want you to think, oh, that could be something serious. I want you to think about a lymphoma. I want you to think about maybe a neuroendocrine carcinoma, sometimes melanoma, metastatic lesions to the skin, leukemia, lymphoma, those kind of things. When they spread to the skin secondarily, all of those are things that you should think about in low magnification. Let's go to higher magnification, and you're going to see that these cells have got this characteristic arrangement of these little cords and strands here with these little residual areas of collagen between them. And that's kind of been referred to as a trabecular pattern. So these are little struts, trabeculae, if you will. Again, I don't know who came up with that name. Maybe they were a construction site worker when they were in high school or something, and then became a pathologist later in life. But to me, I view these as just these irregular aggregations of these cords and strands of cells diffusely in the dermis that have coalesced in some areas to form these more nodular aggregations here. But this is a pretty characteristic pattern of what we see with neuroendocrine carcinoma. And then higher magnification, you look at the cells and they've got this smudgy purple chromatin in them. Smudgy purple chromatin pattern. And you should be thinking of Merkel cell, metastatic small cell from the lung. A lot of atypical cells are pleomorphic. You're likely to see a lot of mitotic figures in these lesions. So this is going to be either Merkel cell, primary Merkel cell, or possibly a secondary metastatic Merkel cell from some other site, or maybe metastatic small cell carcinoma from inside the body that spreads to the skin secondarily. Can't be for sure on something like this. Now, one thing that's a clue that you look for, if you see this little kind of pale, sort of pinkish, sort of discoloration right around the nucleus, you kind of see that same sort of thing a little bit in a plasma cell when it's got immunoglobulin in there, but this is not actually the same thing. This is a little tiny pink dot almost right at the edge of the nucleus. That correlates with the paranuclear dot pattern of staining with cytokeratin, CK20, when you do that stain. So if you see that on H&E, that helps you that you think, well, this may be a Merkel cell carcinoma or neuroendocrine carcinoma. You don't have to see that. And, sometimes like in a cell like that, I don't really see much of it there. It's not seen in all these cells, but, there it is. And then some others, it's probably present. So that's going to help you. It's going to be confirmatory if you do the stain. And lo and behold, we got a stain over here, and this is cytokeratin, and you can see the nice paranuclear dot staining right where that little pink dot was. So if you see that, it's helpful, and then you can make the diagnosis of Merkel cell carcinoma. Another marker that's really nicely positive, cytokeratin 20 obviously is positive. We like INSM1 in our laboratory. It's a nice nuclear stain, insulinoma 1 marker, and that's very strongly positive in Merkel cell carcinoma. Synaptophysin, carcinomatotic antigen, those are positive as well, but they're not as specific and not as clean a marker as INSM1. So we don't really use those as much in our laboratory because there's a lot of overlap and they're not as clean. These lesions look like a lymphoma. Sometimes they get sent into us as rule out basal cell. You could see why somebody might think that's a basal cell here. Here you might, obviously probably not a basal cell in that lesion, but certainly they usually don't get submitted to us as rule out Merkel cell. It's usually kind of a surprise to the clinician. And in a situation like that, you're going to do these stains. You're going to work the patient up to make sure they don't have lesions elsewhere. You can do a TTF1 stain, thyroid transcription factor 1. If that's positive and the CK stains are negative, that favors metastatic small cell as opposed to the primary Merkel cell carcinoma. It's not 100%, but it favors it, and we do that stain also. So just remember this staining pattern, very characteristic of Merkel cell, and the differential diagnosis includes all these other entities that can give you neuroendocrine differentiation as well. Okay, here we've got the clinical first. So why don't we go skip down and actually, I'm sorry, I hit the wrong thing. This is the diagnosis. Well, maybe you figured it out in the clinical, but maybe not. Let's take a look at the pattern. You should be able to figure it out on the slide. And I probably don't really need to coach you through this, but I will. It's a punch biopsy, inflammatory, lymphocytes, band-like infiltrate, lichenoid infiltrate, skewing the dermal junction, irregular epidermal rhesia, higher magnification, marked epidermal hyperplasia, hyperkeratosis, wedge-shaped, hypergranulosis, right here, wedge-shaped hypergranulosis, hyperkeratosis, and this marked epidermal hyperplasia with these irregular epidermal rhesia, and then this infiltrate consisting almost wholly of lymphocytes. And it's obscuring the dermal junction right here. So hopefully you've all been yawning and saying, well, that's classic Lichen planus, and it is Lichen planus. So there's really no question about the diagnosis here. Now, what's unusual about this a little bit is that this is so-called hypertrophic lichen planus. Normally, you don't get this marked thickening of the epidermis with the pseudoepitheliomatous hyperplasia here. And the clinical that I showed you before is a good example of that. You get these verrucous lesions, not the small flat top pink polygonal papules with Wickham stria. In hypertrophic lichen planus, they look like warts. They're very thick and verrucous, and they actually can simulate, in some cases, a squamous cell carcinoma or keratoacanthoma. So going back here, if you take a shave biopsy of this and you just submit us just the surface of this lesion, so let's say you just decide that you're just going to submit this for diagnosis, right here, just this piece right here, you're not going to get back a diagnosis of hypertrophic LP on something like that. You probably get back diagnosis of maybe prurigo nodularis, might get back diagnosis of, if it's atypical, maybe even squamous cell, keratoacanthoma. So once again, you live and die by the shave biopsy. And it's not a great thing when somebody's got pre-tibial hypertrophic LP to get back a diagnosis of squamous cell carcinoma, like you might see if you just looked at one of these, keratoacanthoma, and then start whacking on somebody's pre-tibial area. It's not going to heal well. It can end up as a lawsuit. So make sure that if you remember this diagnosis and give a reasonable punch biopsy that allows the dermatopathologist to make a diagnosis, because if you just get a shave, you may get a wrongful diagnosis, and then you can end up in a lawsuit. So just beware of that. Just remember that when you shave pseudoepitheliomatous hyperplasia, either this condition, the infectious condition we talked about before, you're liable to get back a wrong diagnosis. So just the shave biopsy is not good in these settings. It can give you it can be misleading, and it's not a good situation. So we want to get a punch biopsy to make sure, and basically what this disease is, it's lichen simplex chronicus superimposed on lichen planus. So if you just do a shave, you're only going to get the diagnosis of LSC. And if it's got some atypia because of the pseudoepitheliomatous hyperplasia, you might get back a diagnosis of KA or squamous cell. So just remember, take a good deep punch in order to make that diagnosis. Okay. Last one we're going to do today is this one. We got a punch biopsy. Okay. And at low magnification, is it inflammatory or neoplastic? Well, sure doesn't look like there's a lot of inflammatory cells here, does it? We've once again got spaces, holes in the epidermis. So something's going on to cause these clear areas. So we've had Leishmania giving clear areas. We've had silicone giving clear areas. Well, maybe this one we've got something different giving clear areas. And yes, by goodness, look at this. We've got these vascular spaces that are giving clear areas. So blood vessels. Now, if there's a lot of blood vessels and they have a lot of red cells, they're not going to look clear. They're going to look like they're filled with red blood cells. Or if they're thrombosed, they're going to look like they're filled with red cells that are involved in a thrombosis. But here we've got all these irregular, jagged, bizarre blood vessels that don't really have very many red blood cells in them. And when you get a neoplastic disorder, where there's a lot of blood vessels, they may not have a lot of red cells in there. So some hemangiomas, for example, they may not have a lot of red cells inside their lumen. If you get a malignant neoplastic vascular process, you may not have a lot of red cells. And here you've got all this very diffuse process. So we see neoplasm, we'll take it by punch technique. So once again, we can't assess breadth, symmetry, circumscription, those sort of things, but we can notice that it's diffuse. It goes from side to side and pretty much from top to bottom here. So that isn't a good sign. That means we punched into a sea of neoplastic areas. So that's a sign of very poor circumscription and breadth in all likelihood. So let's go to higher magnification. And, is it symmetrical? Well, no, you got these bizarre jagged blood vessels here. You got some smaller areas over there. There aren't as many. So we can really infer that this thing is very broad, asymmetrical, poorly circumscribed, and it's got all the architectural features of malignancy. And so at a higher magnification, these are regular, jagged staghorn blood vessels with these endothelial cells that are bizarre, atypical, with hyperchromatic nuclei that are floating freely within the lumen of many of these right here. So this is a classic example of an angiosarcoma. And they probably, to the credit of the dermatologist that did the biopsy, this probably was a giant plaque. And they just said, well, gosh, we can't sample the whole thing, so let's take a large punch biopsy. So if you're taking a punch for a neoplasm, it's okay if it's a broad punch, because it's almost like an incisional biopsy. But don't take a 2 millimeter punch. Don't take a 3 millimeter. Take something that's fairly big, and then beware of doing a shave on something like this. So once again, if you had a superficial shave biopsy of this area here, no diagnosis. No diagnosis here. You get nothing. And then, you're not going to be able to get a diagnosis. And, you're dealing with a serious, fatal cancer. And if you delay the diagnosis because the biopsy is not adequate, that can be a medical legal situation. So beware of that also. Take an incisional or a punch biopsy, something that's a broad punch, that's going to allow us to assess all of these various features that we're able to assess in this case. And this is a relatively well-differentiated angiosarcomas. There can be some that are so poorly differentiated in spindle cell with lots of cells that you really need immunoperoxidase stains to make the diagnosis. This would be a one that's relatively well differentiated. And there can be several different forms. Probably the one we see most commonly in derm are these on the scalp, where somebody looks like they've got a bruise. You take a biopsy and then it shows this. Just beware of doing shaves again of this. Please take an incisional or a punch. Another example here, breast, very common to get post-breast cancer surgery, breast cancer radiation, angiosarcomas, the post-breast mastectomy, Stewart-Treves angiosarcoma of the lymphatics of the blood vessels of the upper extremity, quite common. Not as common today because we're not doing as many radical mastectomies for breast cancer like we used to. But just remember, this is a lesion that you really need an incisional or a deep punch biopsy in order to make the diagnosis. And clinically, just remember, bruise, it didn't go away. Think of this. Think of CD20 positive intravascular lymphoma. So think of a CD 1, 2, 3, 4, 5, 6 hematodermic neoplasm, dendritic dermal neoplastic lymphoma. That can give you a bruise that doesn't go away. So bruises that don't go away, think of vascular neoplasms and think of some of these weird lymphomas. And then, of course, think about thrombotic vasculopathy. So if you wanted to work this up, basically you look at these various vascular markers. You don't really need those here. It's obvious vascular. You don't really need this to make the diagnosis. And there was an obvious malignancy in this situation as well. So thanks again for listening. I hope this was educational for you. We had a lot of really good cases today, and we will see you in the next session.